Chronic diarrhea. First, we consider the possibility of fecal incontinence, do a rectal examination, and rule out a poor anal tone. Rule out iatrogenic causes like drugs, surgery, and radiation. Chronic infection, IBS with diarrhea, functional diarrhea. If there are no alarm features, consider food intolerance, bile acid diarrhea, and SIBO. The basic tests that we do in the blood are CBC, thyroid, blood sugars, CRP, TTG, IgA, IgA level. And in stool, we check for fecal occult blood, fecal leukocytes, a calprotectin or lactoferrin, stool for ova cysts, culture, PCR, stool fat. If there's no diagnosis by now, colonoscopy and small intestinal biopsy helps us to diagnose celiac disease, IBD Crohn's, giardiasis, intestinal lymphoma, Whipple's disease, eosinophilic gastroenteritis, amyloidosis, mastocytosis, and tropical sprue. Chemical analysis of the stool can be done in order to check for stool sodium and potassium, stool pH. If it's less than 6, it suggests osmotic diarrhea due to carbohydrate malabsorption. Stool osmolality can be checked, and then we calculate the fecal osmotic gap, which is 290 minus stool sodium plus potassium. And if it's less than 50, it's a secretory diarrhea. If it's more than 100, it's osmotic diarrhea. If the stool fat is more than 14 grams in 24 hours, it strongly indicates fat malabsorption. The approach to chronic secretory diarrhea. First, exclude infection. Stool culture, stool for ova and cysts, cryptosporidium, giardia, plus or minus CMV PCR, PCR for trophaema with Li. We exclude structural disease by doing a CT or an MRI abdomen and pelvis with an enterography. Colonoscopy plus biopsy, small bowel mucosa biopsy plus aspirate for culture, and we can also do a capsule enteroscopy. Selective testing can be done in special circumstances, like testing for calcitonin, chromogranin A, gastrin, somatostatin, VIP. Histamine 5-HIAA. Metanephrines can be tested if there are symptoms of flushing, or there is a hard liver on examination, or there is urticaria pigmentosa. ACTH stimulation done for Addison's, TSH testing, immunoglobulin levels can be tested to look for IgA deficiency, and CVID, which presents like celiac disease, and serum protein electrophoresis. Empirical trials can be done like a low FODMAP diet, which is fermentable oligo-di and monosaccharides and polyols. That's FODMAP. Bile acid sequestrants like cholestyramine can be tried, and antibiotics for SIBO can be tried, like rifaximin. The approach to chronic osmotic diarrhea. We take a good history to rule out laxatives, antacids, sweeteners, and acarbose. Fasting stops the diarrhea. An increase in osmotic gap. If present, we can check for stool magnesium content, stool PEG content. Stool pH of less than 6 indicates carbohydrate malabsorption. We can also do a breath hydrogen test with lactose, plus or minus a mucosal, which is a duodenal lactase assay to check for lactose intolerance. And then we can try an elimination diet. The patient would also have symptoms of bloating and flatulence because fermentation of carbohydrates happens in the colon, which produces short-chain fatty acids with hydrogen and carbon dioxide. And this is what causes the gaseousness. Breath hydrogen test can also be used to diagnose SIBO by the use of glucose instead of lactose. The approach to chronic inflammatory diarrhea. This is defined as chronic diarrhea with blood or WBC in stool. Differentials include infections like amoebiasis, CMV, Yersinia, TB, IBD, pseudomembranous colitis, mesenteric ischemia, radiation enteritis, and neoplasia. All these conditions can also present as secretory diarrhea. The other tests we do are colonoscopy and biopsy, MRE or CTE, stool culture or stool biofile. And we can do an enteroscopy with a mucosal biopsy. The approach to chronic fatty diarrhea. We exclude structural disease with a CT or MRI abdomen and pelvis. We can do a small bowel biopsy and aspirate for culture. Then we exclude pancreatic exocrine insufficiency. The easiest thing to do is to give them a trial of birth and see if the diarrhea reduces and if they gain weight. We can do a fecal elastase testing, which is supposed to be more sensitive than a chymotrypsin in stool. Elastase, the normal is more than 200 micrograms per gram stool, and for chymotrypsin, the normal is more than 8 micrograms, 8 units per gram of stool. Elastase, if it's less than 100, it suggests severe exocrine insufficiency, while a chymotrypsin in stool, if it's less than 5, it's severe insufficiency. The secretin test is a gold standard, but it's an invasive test. Secretin is given IV and a tube is placed endoscopically in the duodenum. Pancreatic fluid is collected every 5 minutes for 30 minutes and it's analyzed for the volume of the fluid, bicarbonate concentration, and enzyme content. With normal response, the peak duodenal bicarbonate will be more than 90 millipalons per liter, but it's abnormal if it's less than 80 millipalons per liter. The disadvantages are it's invasive, time-consuming, and it's only present in certain centers. Thirdly, we exclude duodenal bile acid deficiency. We can give them a trial of bile acid replacement. Postprandial duodenal aspirate can be checked for bile acid concentration. Maldigestion is because of disease like chronic pancreatitis, a lack of bile as in primary biliary cirrhosis. Fecal fat is usually higher in maldigestion rather than in malabsorption. It's usually more than 30 grams per day. Malabsorption because of mucosal disease. If the fecal fat is more than 9.5 grams per 100 grams, it suggests a maldigestion. The steps would include you look for structural problems by a CTE or an MRE, small bowel radiography or biopsy, small bowel aspirate is sent for culture, for SIBO. We rule out celiac disease by a TTG-IgA and endomysial antibodies. The treatment of diarrhea. First and foremost is hydration. ORS has 90 millimoles per liter of sodium. Ham's ORS is high amylose maize starch ORS. This enhances the production of short-chain fatty acids and increases absorption of fluid in the colon. This is supposed to be superior to ORS. If the prevalence of bacterial or protozoal infection is high in that community, empirical rifaximin or quinolones can be used if the diarrhea is more than 1 week. We can consider metronidazole or nitazoxanide as well. Resicadotril, 100 milligrams thrice a day, which is 1.5 milligrams per kg thrice a day. This is an encaphelinase inhibitor and it increases the effect of endogenous opioids on the mu receptor. That's used in acute diarrhea. Opiates can be used, which is mu receptor selective. Codeine in the dose of 15 to 60 milligrams 6 hourly, tincture of opium, loperamide, diphenoxylate. Alpha-2 blockers like clonidine can be used at 0.1 to 0.3 milligrams 3 times a day. It's useful in diabetic diarrhea. Somatostatin analogs like octreotide can be used for carcinoid syndrome, dumping syndrome, chemotherapy-induced diarrhea, and AIDS. Bile acid binding resins like cholestyramine 4 grams 1 to 4 times per day or cholestipol can be used. Fiber, psyllium 10 to 20 grams daily changes the watery consistency to semi-formed stool. Calcium supplements are useful and so are zinc supplements. Rome 4 criteria for functional diarrhea. Loose or watery stools without abdominal pain or bloating. In more than 25% of stools for the past 3 months with the onset at least 6 months prior. Food allergies are seen in 1 to 2% adults. For substances like milk, egg, peanuts, soy, wheat, fish, shellfish, banana, avocado, walnut. Diet-induced diarrhea also could be due to caffeine, lactose intolerance, sugar-free sweeteners. Microscopic colitis includes lymphocytic and collagenous colitis. Lymphocytic and plasmacytic infiltrates are present in the lamina propria, but collagenous, there's also thickening of the subepithelial collagenous table. The mucosa looks normal on a colonoscopy. The risk factors include middle-aged women, autoimmune diseases like hypothyroidism and arthritis. Smoking is a risk factor. Drugs like NSAIDs, PPIs, statins, and SSRIs are implicated. This is supposed to be linked to HLA-DQ2 and HLA-DQ1 and 3, which are also associated with celiac disease. And it's associated with celiac disease. And these patients with celiac disease do not respond to a gluten-free diet. They continue to have diarrhea. Treatment includes bismuth, mesalamine, prednisolone, and of course we stop the offending drug. Dumping syndrome. This is post-gastric surgery. The clinical features are flushing, hypotension, hypoglycemia, and diarrhea soon after a meal. It's due to unregulated gastric emptying, osmotic shifts, and a rapid release of peptide hormones. The treatment includes diet modification and the use of octreotide. Other causes of diarrhea due to gastric surgery include SIBO, bile acid malabsorption, and decreased stimulation of pancreatic secretion. Teduglutide is an epithelial growth factor which helps in adaptation post-bowel resection. Ileostomy diarrhea. The causes are stomal stenosis, SIBO, partial small bowel obstruction, medication, and a recurrent tumor. The treatment includes metronidazole, probiotics, mesalamine, and if idiopathic, may need loperamide and octreotide. Bile acid diarrhea. This is due to chenodeoxycholic acid and deoxycholic acid, which reach the colon in concentrations more than 5 millimoles per liter. This causes colonic secretion of fluid, and that's what causes the diarrhea. There are 4 types. Type 1 is due to ileal resection or terminal ileal disease. There is poor enterohepatic circulation and increased bile acid synthesis in the liver. Type 2 bile acid diarrhea is idiopathic, and this is supposed to be due to a decreased level of FGF19, and this causes a defective regulation of bile acid synthesis. Type 3 bile acid diarrhea is post-cholecystectomy. It happens in 20% patients post-cholecystectomy. And there is no reservoir of bile acid, and therefore a lot of the bile acid is constantly present in the ileum, causing diarrhea. Type 4 is a congenital problem. It's ileal bile acid transporter defect. Antibiotic-associated diarrhea. This could be by 3 mechanisms. Firstly, impaired carbohydrate metabolism by colonic bacteria, causing an osmotic diarrhea. Secondly, Clostridium difficile multiplies and toxin produced by it causes pseudomembranous colitis. And thirdly, erythromycin can increase gut motility, causing diarrhea. Tube feeding diarrhea, that's through the NG or the NJ. This can happen because of the use of hypertonic fluids. The treatment is to change to isotonic fluids and give it at a slow rate. Factitious diarrhea is nothing but laxative abuse. This could happen because of bulimia, somebody trying to lose weight and takes laxatives for that purpose. Munchausen syndrome, the patient relishes being a diagnostic challenge and therefore he keeps taking laxatives. Paul syndrome, which is Munchausen syndrome by proxy. This is poisoning by a caregiver for certain reasons. And then there is secondary gain. For example, a pending disability claim.